I'm Laura Von Seggern. We're here at ISC 2020 in the Frazer booth. I've got Dr. Spokoyny here with me. She's with Sutter Health Mobile Stroke Unit. How are you doing today, Dr. Spokoyny?
I'm great. Thanks so much for talking with me.
Absolutely. Thank you so much for letting us borrow your unit. So, can you share a little bit about your professional experience when it comes to stroke?
Absolutely. So I did most of my training in San Diego. So I did medical school as well as neurology residency down there. I moved up to the Bay Area about 6 years ago. I did my fellowship at Stanford and then did a research fellowship following that, after which I took a job with Sutter Health, where I've been doing clinical care, stroke care, neurocritical care, as well as running the mobile stroke unit program.
Wow, that's a lot. What are the biggest challenges in stroke treatment today?
I think the same challenges, as tales of old time that remain to this day are still really time. So identifying the right patients to get treated and then getting to them in the right amount of time. And I think looking at the time breakdowns, we've done so much to optimize once the patients come in and what we do in the hospital. We're now starting to venture into the pre-hospital field, and there's still a lot of work to be done even before that in terms of patient education and recognition of stroke.
Fabulous. How did you first learn about mobile stroke units?
So actually at ISC, I don't know how many years ago, there's a presentation from some of the German groups talking about their research and hearing about STIMO and there's mobile stroke units that they were deploying, and it just sounded like, wow, this is the future, and then hearing more and more about it since that time.
Awesome. As someone who's dedicated many years to stroke treatment, what are the benefits of having a mobile stroke treatment unit?
Yeah, I think, again, we're back to that question of how do we treat more patients, how do we offer more patients the right treatment, and so being able to cut our times drastically by getting to the patient and giving them thrombolysis in the field, before they get to the hospital, is a huge benefit. The other major one comes to systems of care. So now we can identify which patients need to go to which hospitals and get them to the correct hospital the first time around, because we know that transfer delays are another significant barrier to, optimal treatment and recovery.
Awesome. What features make this particular unit so unique for you guys?
I would say our team, because our team is the best. But the things that make it unique, I know that some of the other units are much larger, and so especially in our county, it's very important for us to be able to navigate our topography, our hills, our roads, and so being able to drive this and maneuver it. And that said, I've driven it one time. They don't let me drive it. But having our EMTs and paramedics who are trained in driving it, being able to navigate it so easily, I think really makes a big difference.
Fabulous. And how big of an area does this mobile stroke unit cover?
And so our area is defined more in terms of catchment rather than miles or minutes. And so what that means is depending on the hospital area that we're covering, which initially was just the area surrounding Mills-Peninsula Hospital, which is the Sutter Hospital where we began, we were able to respond to all stroke patients who would naturally come there following our San Mateo County EMS policies and procedures. And we're currently expanding to cover a separate hospital, Sequoia Hospital, which is in the southern part of our county, so we'll alternate weeks, going one week in the north and 1 week in the south, and again, we'll cover their catchment area who would naturally arrive to that hospital.
Awesome. And how is your unit staffed? You talked about your great staff, so now's your chance.
Yes. So we have, just like a regular, fully functional 911 ambulance, we have an EMT and a paramedic who are excellent, and we have a specialized crew. We work with AMR, and they've been wonderful partners through all of this, but we have a subset of their AMR crews who have been specially trained on stroke, so they get fun lectures from me. They get driving tests and driving, training with the unit, because it is a little bit different, learning how to level, how to do all of that. In addition to those great crews, we have our stroke nurse. So typically that's Jorge Delgadillo, and sometimes it's Eric Pankowska. They'll alternate a little bit. We have our CT technologists. There are two of them who alternate, and then myself as the stroke physician, who I am on board the majority of the time, and then sometimes via telemedicine.
Fabulous. Can you walk us through a typical call, like after it's come in? What's the response?
Yes. Absolutely. So we work very closely with county communications in San Mateo County to set up our program. And so we are fully integrated into the 911 dispatch system. So what that means is when they get a call and they think this might be a stroke, and that's not just hunch, it's very algorithmic, so they use their dispatch protocols and decision trees. So if it comes out as certain cards that are indicative of stroke, we will get tandem dispatched with the regular 911 ambulance. So it'll be ourselves, the regular 911 ambulance, who's also AMR, as well as fire. Typically, fire will arrive first. It will depend on where everyone is located at the moment, but for the most part, their response time is first. And then either ourselves or the other transport ambulance will arrive next. We get there, we assess the patient, and the first question is, does this seem like an appropriate patient for the mobile stroke unit? Now, there may be stroke patients who we don't transfer on the mobile stroke unit. Why might that be? Well, let's say that they're on anticoagulants and we know that they're not a candidate for thrombolysis if they've been taking them consistently. Let's say that they're coming in and we got activated because it was less than 24 hours, but we find it's really a good onset time and it's 19 hours ago. We're not going to transport that patient. Several reasons for that. One is we have one mobile stroke unit, so we want to be the most available to the most patients whom we can help and we can treat. And then also the patients who are out of the window, perhaps when they go to the hospital, they may be treated off-label, and so their benefit is actually getting to the hospital as quickly as possible. So we decide if we're taking the patient or not. If we do decide that we're taking them, we bring them onto our unit, so our gurney comes out, the patient's loaded on, we make sure we have at least one good IV, and then we're able to start our CT scan. So our CT scan takes about a minute and a half. In order for the CT scan to be done, as you know well, we have to be level. So we tend to find ourselves in a relatively flat area, and then we use the auto leveling function with all of the stilts that are on the bottom of the unit, or is there a better word for that? We use the stilts on the bottom of the unit to perfectly level so that we can move our CT scanner in place, do an on-contrast CT scan. I can immediately review the CT scan once it's done. We have a workstation right at the back of the unit, and assuming that there's no hemorrhage, there's no significant early ischemic changes, there's no reason why I wouldn't want to give this patient thrombolysis, we give the go-ahead, we mix the TPA. All of the rest of it, once the CT scan is completed, can be done while we're driving. And so the part on scene is really through the time of the CT scan, and that's what makes us so quick from 911 call to TPA. So we can give TPA, we can control blood pressure if we need to. If we find that somebody's having a hemorrhage, we have blood thinner reversal agents. We also have blood pressure agents on board, of course. So we can do all of the medical management and then drive to the hospital. And as we're driving back, there's the additional pre-notification. So the paramedic is giving their normal ring down. So myself, I'm calling the stroke neurologist and often the interventionalist who are in the hospital. Now they've been pre-alerted. And so that's really where this can sort of flourish, is we're activating all of these systems of care in parallel.
Fantastic. Let's see. What was the collaborative process with Frazer like to get your mobile stroke unit started?
So first of all, before we even made the decision to invest in a mobile stroke unit, Frazer connected us with other programs who had them, and so that was a good learning experience. How did you do things? What struggles did you have, or what were the easy things about it? Following that, Frazer really walked us through the process, which was so helpful because we hadn't previously been in the business of buying mobile stroke units. So something new for us. So kind of what are the components? Where should things go? How should things be laid out? And really getting that guidance. Once we did buy it, then we had implementation calls that were almost weekly, going through, how are things going to go? Once we get the unit, this is how, this part is going to come and this is going to get installed, et cetera. And then the actual activation. And since then, we've had follow-up calls, troubleshooting, and a lot of collaboration for, continued growth.
Fabulous. And what are your short and long-term goals for the program?
Yes. So Sutter Health is an integrated network. It invests in innovative projects like this one, and so we've been lucky to have that support and the philanthropy support to get the program going and sustain it thus far. We're participating, as you know, in the Best MSU clinical trial. The main site for that is University of Texas Houston with Dr. Jim Grotta. So we're very pleased to be part of that and enrolling really well in that trial. we're hopeful that with the results of that trial, as well as the results of Be Proud, which were just presented today at the main session at ISC, which showed that there was a benefit functionally for these patients who are treated on the mobile stroke unit compared to regular transport, that this will become something that becomes much more widespread. And so that will influence our sort of short-term and long-term goals if we can get larger payers to, kind of get behind this and really change the landscape for pre-hospital stroke care.
Great, great. How does it feel to play such an important role in something so new and innovative?
Yeah, I mean, it's awesome. It's something very different than what I was doing before, than kind of we typically do as stroke neurologists. We're in the hospital. We're a couple layers removed, even from the patient coming to the emergency department. So it's been a humbling experience, and I no longer complain about why nobody knows the last known normal, because it is very hard to get that on scene. But it's really truly been an honor to be working on this program and helping it grow.
Fabulous. Thank you so much. Everybody, please go to www.frazerbilt.com. If you missed this, we'll have that playing on our Facebook and our Instagram. And you can get all of your mobile stroke unit information there. Thank you again, Dr. Spokoyny. I really can't thank you enough.
Thank you.
All right.